So good afternoon, everyone. And well, first of all, let me thanks to the scientific committee for giving me the opportunity to be presenting here today. And we are going to talk about the usage of cell-free DNA in the analysis of products of conception. And as you can see in the subtitle, we think that with this new approach, we can cover a gap in the study of aneuploidies in pregnancy loss. This is my disclosure. And well, as a super brief introduction, all of you know that there are dozens of factors described in the scientific literature that can be the cause or can contribute and increase the likelihood of suffering or having a miscarriage, a pregnancy loss. But among all these factors, there is only one that yet accounts for 50% of all the miscarriages. We are talking about aneuploidies, and these figures could be even higher, up to 60% in the IVF population. If we talk about the general obstetric population, it's well known that this is not a rare event. So 15 to 25% of all the pregnancies could end in a pregnancy loss. Regarding according to the scientific and professional guidelines, regarding the management of these cases, nothing is recommended regarding testing. So there is no recommendations in testing or start testing in patients when they have an isolated miscarriage based on different reasons. Perhaps 4 good reasons could be the ones that you have in this slide. So the first one is that the likelihood of having another consecutive miscarriage are quite similar to the starting point, so 15 to 25% to have another consecutive miscarriage. Obviously, testing costs money, and obviously, if some of this testing is genetics testing, you need the fetal remains, and getting these fetal remains many times is through invasive or surgical procedures that they have risks associated, although they are low, but they have risk, and some doctors, they don't want to to assume those risks with the patients. And even if you take the risk and you perform the sampling and you perform the genetic analysis, if we think globally, the most extended testing all over the world is the karyotyping due to different reasons, because it's classic, because it's what is feasible, or because it's what is included in the systems, in the public health system, or covered by insurance companies. And the problem with this kind of genetic testing, that is a wonderful testing, don't get me wrong, but regarding the pregnancy loss has several limitations that in some cases you are managing an information that could be misleading or plenty of uncertainties and cannot help a lot in the reproductive management for these patients. Some of these limitations are the ones that you can see in this slide, and some of these limitations can be overcome with the usage of molecular techniques like the next generation sequencing or the chromosomal microarrays, in which, for example, no cell culture is required. Sometimes the tissue that we get is not so vital, so it's not growing, or is growing so slowly. The turnaround time getting the results for the management of the case is shorter. In the case of the molecular testing, the percentage of informativity is way better. So we are talking that with the karyotype, we are getting some, on average, 50% of the cases are informative. With the molecular approaches, is more than 80. In the case that we are performing the sampling with hysterembryoscopy, we can reach virtually to 100%. We don't have any sort of false negative due to maternal site contamination, because with all these techniques, with the molecular testing, usually we perform STR analysis just to identify if the DNA that we are isolating from the tissue is from the mother or from the fetal tissue. And in case we use, for example, chromosomal microarrays, we are getting greater resolution. So much better, but still doing the analysis in the fetal remains. What is the problem? The problem, and this is our experience, and for sure is your experience, and it's been described in many different articles, and this is just an example. One fantastic article that I recommend you to read if you can is a work from Dr. Tanya Schlager-Hartwig. And even if you want to get the tissue in all your cases, there is a percentage of them in this article. They described that it was like a third of all these cases in which it's impossible to get the tissue just to perform the analysis. So you lose the opportunity to know about the genetic status of this miscarriage, okay? And that it should be convenient just to have an alternative, a technique that is tissue independent, just to understand what is happening. In this part of the slides, you can see that whenever you want to perform the analysis, this is the percentage of cases in which you don't have access to this tissue. And when you perform the analysis, there is a percentage of cases in which what you are analyzing is maternal cell contamination. So no clue, no information for the clinical management, okay? But we are talking, the subtitle of this talk was covering a gap. And the gap, it's an important gap. So we can define the gap as all those patients in which they suffer or they have an spontaneous pregnancy loss, and in which the management is not surgical management. They are not going to go through a dilatation and curettage or aspiration or a private evacuation, getting the tissue just for the analysis. So they are going to have the misoprostol or the cytotec pill to have this evacuation privately at home, and they are not going to recover this tissue for analysis. So no information for those cases. When you talk with doctors and you say, okay, would you like to know the aneuploidy status of this miscarriage? The answer is always yes. So we are losing, or these patients remain untested all the time. And even if you take the tissue, as we were saying before, there is a percentage of cases in which no information is going to be available. So this is the gap number 2. So important percentage of patients in which doctors would like to have the aneuploidy testing done, but it's not feasible because they don't have the tissue, the fetal remains, available for analysis, or this tissue is not it doesn't have the quality or the quantity, that is needed for the analysis. What we know, what is the alternative that we are describing today? And for sure, you've heard something in different conferences before this one, is the usage of the cell-free DNA that is circulating in the maternal bloodstream to perform this kind of analysis. So the procedure, as you can see in this slide, is simple and straightforward. It's just to take a blood sample, a peripheral blood sample, in which we have the plasma, the blood plasma. There we have the cell-free DNA with all the DNA from the maternal organs and tissues. And if this woman is pregnant, obviously there is one tissue that is releasing the cell-free DNA to the maternal bloodstream, that is the placenta. And with all this, what we can do, and this is the regular procedure for the NIPT, for the non-invasive prenatal testing that you already know, at the end of the road, what we are doing is a bioinformatic analysis just to assess if the ratios of the chromosomes that we are analyzing are correct, or there is an anomaly that we can detect in the maternal bloodstream. If this can be applied not only for ongoing pregnancies, but in miscarriage, this is something that several groups, we have the experience of performing the NIPT in cases that, at the beginning, everybody thought that it was an ongoing pregnancy, but when they performed the sonographic examination on week 12, they discovered that the fetus was arrested several weeks before, and the analysis with the NIPT that was requested to different laboratories, was informative with normal or abnormal results. And additionally, we have the experience of those cases in which we have an ongoing pregnancy with an ongoing fetus, but in which we have a vanished twin. And this vanished twin is well known. That is the first and most important factor contributing to the false positives in non-invasive prenatal testing. And the reason is because although this fetus has been arrested, the cell-free DNA or the DNA from these remains are, released to the maternal bloodstream and can be absolutely detected. But the question is, okay, we detect this DNA, but how reliable is it? So what is the performance? How many cases can escape to the analysis? This is something that should be assessed. The scientific evidence, so the number of articles describing the experience of using the cell-free DNA in the maternal bloodstream, it's different. So it started in 2014 with the description from Cecilia and collaborators that the cell-free DNA from the miscarriage could be detected. Then the group of Yuval Jaron and colleagues and Dr. Antonio Borrell described in 2020 with a good casuistry of cases what was the experience with very positive results. And later on, different laboratories and different scientific or research groups described their experience. This is one of the last studies is the one that I mentioned before that I strongly recommend you to read this article. It's a Lancet and it's a fantastic work with about 1,000 cases, 1,000 miscarriages. And I think that tomorrow in session 6, you have the lecture of Dr. Tanya Hardwick explaining the results. And finally, we published our evidence and our experience with the usage of cell-free DNA in cases of pregnancy losses using a single algorithm. Based on that experience, we decided to perform a clinical validation, but not with a single algorithm of analysis, but with a dual algorithm of analysis with an adapted one that is a proprietary algorithm in iGenomics with more than 150 cases, as you can see in this slide, in which we studied in parallel the DNA content or the DNA information from the fetal remains, that this is an active service that we have for years at iGenomics, at my center. And we dissected and processed this tissue, we isolated the DNA, we obtained the genetic information, and we assessed if this information is maternal or not, taken along with this tissue the blood sample from the mom in an extract tube just to discard or confirm by STRs the fetal origin of the sample. And then with this plasma in the maternal blood sample, what we did is just to perform an NIPT as a regular NIPT is performed with the platform that we are using in our laboratory. And at the end of the road, what we did is a different bioinformatic approach using this dual algorithm analysis. And at the end, we assess the concordance between the information with the invasive POC analysis with the non-invasive POC analysis, getting an 88% of concordance once triploid cases were taken out of this comparison, because what we wanted at that stage was just to compare apples with apples. And you know that the triploidy or the ploidy, changes in ploidy is a limitation in all the NIPTs except one platform that can perform the analysis with the SNP information, okay? So 88% of concordance is quite important in this point, just to point out that the accuracy could be importantly improved in all the scientific evidence that you can find today in the scientific literature. These are the 4 main studies and experiences with the groups that are published, the results in the scientific literature, and you can see how the accuracy using the basic and native NIPT algorithm could be importantly improved when the algorithm is adapted for miscarriages. This is our experience too, and you can see how this, on average, for all the laboratories, explaining the accuracies, it seems that this adaptation can improve. You can have more than 10% increased accuracy, and this increased accuracy is important because the more reliable is the result for the miscarriage information, the better the reproductive counseling you can give to your patients in the future, okay? Well, why choose to do a non-invasive POC test? or using the cell-free DNA in the future for your patients? Well, the first reason is because it's non-invasive. So it's, as I said, it's simple and straightforward. And many doctors around the world, they don't know or they don't want to perform a surgical management or evacuation, doing DNC, stereoscopy, or whatever, or they don't want to touch the structure, and they rather prefer the patient to have the evacuation privately at home. Secondly, because it's going to be faster. So if you compare with the conventional karyotyping that is taking like 1 month, here we can have, and we have results as early as 1 day, 2 days, 3 days. But in general, we can think that the normal TAT in the future is going to be the one that you have for the NIPT service. So I mean, between 1, 2, 3 to 7 working days, okay? Because in addition, the informativity rate is so high. If you compare again with the karyotype, you can see that the karyotype is well established and accepted, that the informativity rate is around 50%. And you can see as this is improved with the new molecular techniques working directly on the fetal remains. We go to the range of 80 to 90%, close to 100 if we use hysteroembryoscopy. But you can see as using the cell-free DNA have figures that are quite comparable to the ones using these molecular approaches, and way better than the one with the karyotype, okay? If we stratify this non-informativity in the different weeks of gestation when the fetus was arrested, you can see how the non-invasive POC gets more informativity, above all in these early stages, week 5, week 6 of pregnancy. And then there is an stabilization up to week 10, and from week 10 onwards, it seems that it's more informative using invasive POC. So this is valuable information that we have to, keep on going and getting this result with more cases just to define better. But it seems that the NIPOC is going to be a good solution for early pregnancies. Regarding the test limitation combines the limitation of any molecular testing, that could be the PGTA or the CMA. That means you can see in these points the limitations, along with an additional limitation that is the one corresponding to the non-invasive prenatal testing, because we are doing the analysis in the maternal bloodstream. And although it's weird to find cases like these cases that I'm describing in the last point, from time to time we can have a maternal condition that is maternal, is not from the placenta or the fetus, and can confuse the aneuploidy colon. So this could happen. In case you know that the mother has an abnormality in the karyotype, there is something to take into account before testing. So regarding who can benefit from this new approach, obviously, and I want to be clear in this slide, and don't get me wrong, this cell-free DNA for me is an amazing advance and an amazing alternative, where before we have nothing. But in case you are comfortable as a doctor, whenever you have a miscarriage, doing a DNC or an invasive sampling, surgical sampling, and collecting this tissue and performing the analysis directly in the tissue, this is the way to go, because it's the reference, is the gold standard. And in case you get informativity in the fetal remains, it's going to be the best, okay? But for those cases in which the management was just, just to give the pill, give me misoprostol or Cytotec, and to have the private evacuation and not having the possibility of testing, now you have an alternative that is highly accurate, simple, and straightforward. Suitable for 3 different situations. It could be suitable. The main recommendations for the of the professional guidelines is only for recurrent miscarriage. So this could be applied, and this could be done in the future in recurrent miscarriages. But obviously, there is plenty of articles and evidence in the scientific literature regarding and describing what is the benefit in every single, pregnancy loss, not in recurrent miscarriage only, but in early pregnancy losses and isolated pregnancy losses, regarding how testing and knowing the reason for the miscarriage can psychologically alleviate the distress that caused this early miscarriage. And additionally, it gives you prognosis when you want to talk with your patients, because at the end, if you have an enabled miscarriage, it doesn't matter that it's isolated. When you have an enabled miscarriage, obviously it's not a maternal factor. And every one of us is at risk of having these kind of events because every one of us has abnormal gametes. And we are, in this lottery all together. So it's a good prognosis because it's the embryo, it's not the mom who is producing this specific miscarriage. Third, it could be suitable. Above all, we think it could be positive for patients undergoing assisted reproduction treatments and having a miscarriage. Why? Because as I told you, one of the limitations in these techniques is that the cell-free DNA miscarriages cannot detect triploids. And although in the ongoing pregnancies from week 10 onwards, it's weird to find this rare to find a triplet pregnancy that is ongoing. In the case of miscarriages, it accounts for about 5% of all the miscarriages. The cause is a triploidy. But in the case of the patients with going through an IVF treatment, because everything is more controlled, everything, the fertilization, the pronuclei production, the number of them, everything. How is the sperm many times? How is the sperm in the male, etc. There are less triploid miscarriages, and these figures can be reduced from 10, 5, or even in the case of the IVF population, 1.5%. So being a limitation is less limitation. And additionally, the NIPOC, this non-invasive POC analysis could be or maybe a new decision-making tool. Why? And this is a real situation. I remember a call from a patient saying, okay, I performed an NIPT because the sampling was, beyond the week 10. We got the result, it was abnormal. She had a miscarriage, and she told me, doctor, is there anything that it can be done on, in my case, because I'm an IVF patient. I went through an IVF cycle. I have some embryos frozen, and I don't want this to happen again. For me, this is a drama, and I don't want, to happen this again. So is there something that it can be done? The reality is that for this patient, perhaps the regular, depending on the medical records, obviously, but the most common management would be to select the next embryo as per the morphology or whatever the criteria is going to be for this patient and transfer this. If this patient doesn't have a native indication for PGTA or non-invasive PGTA, so it's another transfer again. But this woman has said that she doesn't want to have another miscarriage again. For her, it's a drama. So we have to think that for this kind of patients, they have a burden trying to get pregnant at home, a psychological burden that then when they go to an IVF center, this burden, we have to add things. So it's not a psychological burden anymore, not alone. So it's going to be psychological, physical, and economic burden. She succeeds, and then she has this early pregnancy loss. So again, more psychological burden. What is the reason? We don't know, because strictly following the professional guidelines recommendations, nothing is going to be done, nothing is going to be tested. So we are going to your cohort of embryos that we already know that this cohort of embryos is going to be, mixed with abled and unabled ones, and we are going to try again. But she said that she didn't want to go through this again. So it could be a good tool just to perform a non-invasive POC, well, a POC analysis, but since in many places and in many occasions to perform a DNC and go through this invasive procedure is going to be not that simple as the NIPOC, perhaps this approach could help us just to perform the analysis in the case, and just to figure out if there was an anomaly. In case there is no anomaly, just to allows you just to review the medical history of this patient and to decide what you want to do again, to transfer by morphology or whatever you want to do. In case you detect an aneuploidy, obviously the reason is the embryo. And obviously, she doesn't want to get another aneuploid embryo again. So a PGTA could be a good strategy, a PGTA or a non-invasive PGTA, yes, to, that the PGTA, the non-invasive PGTA, is not creating aneuploid embryos, but it's telling you information regarding what are the embryos that most likely are aneuploid, and that has the greater successful likelihood for the next transferences. Okay, so this gives you an order just to reduce the likelihood of having what she doesn't want to have, that is a miscarriage. This is only for isolated pregnancy losses, but what happens in cases of recurrent miscarriage? In cases of recurrent miscarriage, it could be a good tool just to give perspective. Why? Because as you can see in this example, all these 4 patients are recurrent pregnancy loss patients, okay? Recommended by the guidelines to start doing testing on them, but patient number 1 and patient number 2 are equivalent because both of them, they had 2 miscarriages and the last one was analyzed and the result was normal, okay? Patient 3 and 4 are equivalent because the same, they had 2 previous miscarriages, consecutive miscarriages. The first one, I don't know because we didn't do anything, and the second one was aneuploid. So they are equivalent. The recommendations for the first one, obviously, it seems that there is a problem with this woman. And based on the last information, we can recommend an ASRM workup, analyzing all, thrombophilias, endocrine factors, or structural uterine factors, but the couple's karyotype, whatever. Okay. In the case of 3 and 4, exactly the same. It seems that this is an aneuploidy, the last one, so it makes sense that we can help this patient and this couple by doing a PGTA and selecting aneuploid embryos. But look what happened. What happens when we have perspective? And these perspectives could be easier to get if we have a non-invasive POC, this cell-free DNA analysis that is simple and straightforward. So we can have information from all the pregnancies or all the miscarriages in these women. And you can see as now number 1 and number 2 are not equivalent anymore. So it makes sense to perform the ASRM workup in patient number 1, but perhaps not in number 2. And how patient 3 and 4 are not equivalent anymore, and how the PGTA make a lot of sense in patient number 3, but not in number 4. Now the equivalent patients are number 2 and number 4. And what we have to think about is if this information is reliable and this information from miscarriage number 1 and number 2 is different, perhaps there is no consistency in the reason for the miscarriage, and perhaps this was serendipity. And again, this is a punctual, an infection or something that was punctual. And perhaps patient 2 and patient number 4, they are not yet, recurrent miscarriage patients. And we need a third event just to know what is the way that we should go with these patients, okay? And just to conclude, let me read these take-home messages that I think is quite important in couples who have miscarriages to find out the reasons that are behind these miscarriages. And we know that 50% of the causes are an aneuploidy. So I think it's quite important to start analyzing miscarriages whenever we want to find out the cause by the factor that is more frequent, and this is the genetics, okay? Point number 2 is that the non-invasive POC represents a new technical approach, allowing genetic testing in a group of patients that so far have always remained untested. So this opened this opportunity to all those doctors that they were willing or they would like to have these results, and before there were no technical approach to do so. So now it's feasible. The simplicity and accuracy of this new approach may help our patients first to alleviate the psychological distress, improve the clinical management to reduce future miscarriages. This applies especially in IVF patients without a clear indication of PGTA or non-invasive PGTA, and obviously gain perspective when a woman becomes a recurrent pregnancy loss patient. We are talking about knowing the genetic information not only from the miscarriage number 2 or 3 onwards, but having all the information and the big picture in front of our eyes, for a proper management of this patient. Before it was more difficult because technically it was more complex, but now it's super simple and straightforward. And it's of paramount importance to understand the test performance metrics to give a proper genetic reproductive counseling to our patients. So it's quite easy that from now onwards, since we are getting more and more experiences from different research groups in the scientific literature, that many laboratories can be encouraged to launch new services and offer this service to you, to the clinics and to the doctors. But I think it's quite important for them just to have a proper, experience verifications and validations, just to give you reliable information regarding the sensitivity, specificity, accuracy, because this is important information for the pre-test counseling, for this interview that we may have with our patients or with your patients, just for them to understand what are they going through and what is the reliability of the results that they are getting in terms of aneuploidy, false positives, false negatives, and non-informative cases too, okay? And that's all. Thank you very much for your attention, and I'll be glad to answer any questions that you may have. Thank you very much.
So thank you very much, Dr. Stankiewicz, Tiffany, if I might say, Dr. Milan, Miguel, if I might say as well. And thank you for your beautiful lectures. And we were moving from the embryo to the endometrium and also to analyzing these products of conception in a non-invasive way that it's perfect right now. So let me start with you, Miguel. Talking about the non-invasiveness, because we were the other day in a conference and the physicians were like actually eager to start doing the non-invasive POC. So my question would be, do you think that non-invasive POC is going to overcome the invasive POC? You explained a little bit already in your lecture, but could you develop a little bit your thoughts on this?
Sure. Good afternoon. So no, I don't think so. I think that this is a fantastic alternative. Not alternative. This is a fantastic tool for those cases in which to take these fetal remains is not feasible. So whenever you can do it and you can get these fetal remains, we are doing the analysis with 100% pure DNA from the fetus. If the DNA testing by STRs tell us that this is fetal, so there is no better analysis than the one that we can do this way, okay? But the reality, and this is the reason why our group and others have, expressed their experience using cell-free DNA and all this, all this situation, this new alternative, is because it's quite common around the world. We don't have to think about our situation in our country, but we have to think wide. And around the world, it's quite frequent that the management for, in case of early pregnancy losses or repetitive pregnancy losses, is just to give the medical treatment, the misoprostol or the cytotec, just to have your private evacuation at home. So in those cases, you have two situations. Number one is that you are not doing any sort of testing, okay, that this is the most common, or you can get by yourself privately the fetal remains and send this to the laboratory. And in those cases, even willing to have a testing in the fetal remains, the percentage of non-informativity is so high. It's so high, especially in early, weeks of gestation. For example, for instance, week 5, week 6 is too high. So I think that for those cases, or for those cases in which you receive the fetal remains and you see that the only thing that you have is blood clamps and things that you are recognizing that the likelihood of having a non-informativity in the direct analysis is high. So this could be a good alternative just to get reliably information about the causes of this miscarriage. So it's not a substitution. I don't think it's going to be a substitution, but it could be a good partner in this trip.
Okay, cool, perfect. And Tiffany, you were explaining us about the importance of the endometrium, and we know that the endometrial receptivity analysis, the ERA, it's more for patients with implantation failure. Although there are some patients with a misplaced window of implantation that can cause biochemical miscarriages, right? Higher chances to have biochemical miscarriages. But we are at the recurrent pregnancy losses conferences. So I would like to focus a little bit more on the microbiome, because having an altered microbiome, even more having infections such as chronic endometritis or other infections, can cause these recurrent pregnancy losses, right?
Correct. Yeah. I mean, it's upwards of 60% prevalence rates. We see chronic endometritis in patients with recurrent pregnancy loss. So the microbiome is certainly an important area to study, particularly for those patients who had previous pregnancy loss, because it could be as simple as a dysbiosis or a pathogenic problem that can be effectively treated. So we actually have a clinical directive to improve for these patients. And you saw in one of the studies we showed, or of course you're quite familiar with it, but a big difference in miscarriage rate for those patients who have an optimal microbiome made of primarily lactobacillus versus those who don't, who have bacterial pathogens such as Gardnerella and Streptococcus presence. So we know that these bacteria have an effect and could potentially be leading to miscarriages.
So, and following this path, I think that lactobacillus is so important, but I think that it's more important because it doesn't allow to another pathogens colonize the endometrium, right? And that can cause this infection and the miscarriages.
Yeah, so I always like to say lactobacillus are like the safety net or the night guards. They keep the bad guys away, which would be your bacterial pathogens. Necessarily having a high presence of lactobacillus that leads to good outcomes. We know in microbiomes where there's very little biomass, so because there's an objective here that we need to keep, making sure the bacterial pathogens are omitted, allowing for an optimal microbiome, preferably with lactobacillus to be there to keep that constant.
Okay, thank you. And Miguel, did you say from the 5th week of gestation that can we analyze with the non-invasive POC for the chromosomal status of the miscarriage?
You are right. Yes, what we included in our clinical validation is from week 5.
Whoa!
Yeah.
So and you show the table because the no-call rates for the invasive POC in those weeks of gestation is really high.
Yeah.
So this part and this is I've been asked in ASRM this last week that they were asking about. We say that okay, it's so similar to the NIPT, invasive prenatal testing, and why then we can get a result from a 5th week of gestation, but with the NIPT, 10th week and onwards?
Well, two different things. The first thing is that you have to take into account that the informativity rate, see what we got is less fetal fraction. So the fetal fraction on average in the product of conceptions that we've assessed in our study is like half. So if the average in ongoing pregnancies beyond week 10 is like on average in the period 6, so the activity beyond the week 10 is only 1% in our case, for example, and here for the POC is like 10%. So 10% non-informativity is so high in ongoing pregnancies. So what you want is just a tool that is useful and you don't have to repeat the analysis again and again and again. Number one. Number two, the clinical utility of this sometimes is not clear. Why? Because the only condition in which you can rely a lot with the results that you can get in an NIPT whenever is abnormal is a trisomy 21. The rest of conditions that you can test, including sex chromosome aneuploidy and so on, if I see an anomaly, this could be a confined placental mosaicism, and I'm for sure I'm asking the physician. I'm having a conversation with the physician and with the patients just not to have a CVS analysis. Obviously, not to terminate the pregnancy because the positive predictive value for the rest of conditions other than trisomy 21 is not 190%, is below 80%, sometimes 50 or 10%. So it's important amniocentesis that can only be performed on week 16 onwards. So imagine the anxiety that the patient is going to have if you know the results on week 6 and she has to wait 10 weeks just to perform the procedure, but 4 more weeks, week 20, just to get the final results. So it's a long time, make no sense from the clinical point of view, just to test so early. And additionally, because what we have in a product of conception, once the fetal is 5%, 6%, this percentage of fetal fraction, most, cells that are dying are releasing this fetal DNA to the maternal bloodstream. So this is a lot of DNA from a small structure. I don't know if you follow my explanation.
Mm-hmm.
In case this is an ongoing pregnancy, in an ongoing pregnancy of the cytotrophoblasts, that this is a small part of the placenta, are releasing the cell-free DNA. So most probably in week 5, 6, get is lower than 5% of non-informativity and rely less than this 90% informativity. So we will fall in 50% non-informativity or less, and this makes no sense.
I see. So a perfect explanation. I mean, and Tiffany, when we find a patient with a recurrent miscarriage and we control for chromosomal status of the embryo, would you strongly recommend for a physician, because in our audience today, we have a lot of physicians to perform a study of the microbiome. And if so, what would be the technique? Because we are moving from the NGS to a real-time PCR with a target panel. What was the reason to do this movement?
Yeah, so the reason that we introduced an upgraded panel is really based upon our experience over the last 5 years with next generation sequencing. And I think this, coming from iGenomics, we're dedicated to science and we're dedicated to always evolving and improving and offering better products and better testing for patients out there. And the advantage with the RT-PCR is that we're actually able to now provide results at the species level, where previously with NGS, we were giving the genus, but now we can go a step further and give species level reporting. Now, why is this important? Well, it's important because allows us to get an even more targeted treatment when it comes to the antimicrobials that we're giving. So maybe we have 2 different species of, say, Streptococcus, and one will be more effectively treated by one antibiotic, whereas the other one will be more effectively treated by another antibiotic. So this allows our microbiologists and our team to give a more targeted recommendation when it comes to antimicrobial therapy. So not only are we optimizing the outcomes further for the patient by getting them to an optimal microbiome much sooner, but I think we're also doing our part in general to prevent antibiotic resistance when we have targeted antibiotics versus broad spectrum antibiotics, which is super important.
Okay, that's great. That's great. We have to finish now, but I would like to ask you, Miguel, for your personal opinion. I mean, and tell us whatever you think, of course, because you know that for the recurrent pregnancy losses, usually they say, no, you have to wait until the 3rd one. There is a paper from Dr. William Kutte, you know, from 2018, talking about, okay, after the first, but the second one you have to test, and it's better to test first for the chromosomal status of the products of conception, because we will get more than 50% of those miscarriages. Would you test from the very beginning, from the first one? You were explaining that on the slides, and for me also makes sense, but would you recommend to our physicians here now, the medical teams, to start testing at the very beginning?
So it's difficult. I can give you my opinion, but it's difficult just to recommend something when the people that is managing everything with the patient are the doctor. So they have to understand.
Just your opinion. I'm asking just for your opinion.
My opinion as a geneticist, you know, that we always are willing to knowing everything. For me, just to have perspective is valuable. Gives you a lot of information regarding what can be miscarriages that are happening. So whenever you have something that is consistent, then you have clues, you have information just to, you know, the future treatment. And the best example is whenever you have a patient doing PGTA for a long time, and sometimes you have read that the indication is PGTA, and you observe that normal. So I think that having perspective, we are gonna, you know, avoid that some patients go through PGTA procedures that are unnecessary, because the reason is. So whenever we have a recurrent miscarriage patient, if we have the history, we can determine, is there something consistent? Yes. So if this consistent in this way, this is the solution. If this consistent in the other way, we have another work. In case we have to, you know, keep on going and having more data just to understand what is the direction. Perhaps we need, with 2 consecutive miscarriages, we need a 3rd miscarriage just to understand if 2 are normal. Perhaps we have this mix, and the problem is the mom, and we have serendipity. And the second was abnormal just because serendipity, because we have abnormal gametes. But there is a maternal, you know, problem that is arising with the 3rd one. Do you see my point? And the same the other way around. So if we have 2 abnormal miscarriages and only 1 normal, obviously we have a repeated condition, and perhaps PGTA could be a good strategy for them. But again, this is my opinion, and I'm geneticist, and for sure I'm biased, but makes sense. For me, makes a lot of sense.
Okay, so I think that we went through all the landscape. We checked for the chromosomal status of the embryo, and we do know that this will help to analyze the embryo, will help to our recurrent pregnancy patients. Also, we check for the endometrium. We observe that it's really important to analyze, to know that the patient infection, no pathogens at all. And also in cases and happens that miscarriages, it's important to know the condition and why this happened, to have the information, but also for the emotional burden of the patients, right? So I guess that it's time to close not only this session, but also this first day of recurrent pregnancy losses and human reproduction 7th annual conference, where we started with a great pre-course of artificial intelligence. We and infertility, Gating the Hope, and this last session that we have just finished. Please don't miss tomorrow, the second day of the conference. I can tell you that there will be a lot of interesting. And I would like to thank again to all of our speakers, including, of course, Dr. Tiffany Stankiewicz, Dr. Miguel Milan for being here today. And also, of course, to all of you for staying with us. And wishing peace for all of the world, including, of course, Ukraine and Palestine.